Good evening, everyone. Today I'm going to be presenting a case. I am Dr. Rutuja Malekar, and my initials are RUR, and the moderator for this class is Dr. Rajm, sir. A 62-year-old male hailing from Muzaffarpur, he presented with chief complaints of sudden painless diminution of vision in the right eye since 2 months. He noticed the sudden drop in vision upon waking up in the morning. There was no history of pain or redness, no history of flashes and floaters, no history of previous episodes in the past, no history of trauma, no history of vomiting, headache, tinnitus, diplopia, and no other significant past ocular history.
Wait, wait. Okay. Okay, can anyone tell me what all you'll expect? Differentials? Having the mic?
Sir, sudden painless vision loss can be due to vitreous hemorrhage, central retinal vein occlusion, central retinal artery occlusion, retinal detachment,
Hmm.
hyphema.
Okay, so what all will you ask to rule out each one of them?
Painless sudden diminution of vision, most common causes CRVO. History of trauma in case of retinal detachment and vitreous hemorrhage will be there.
Okay, so there is no history of trauma in our case. Then,
History of flashes and floaters to rule out RD.
can RD occur without flashes or floaters? Can still occur. So just because of a negative history does not rule out RD. Next person. What else he said?
History of vomiting, headache,
Why do you want to rule out vomiting, headache in a patient with sudden painless defective vision?
papilledema, sir.
Huh?
Papilledema.
Papilledema. Okay, very good. Can someone define papilledema? People have a mic here. So,
Swelling of the bilateral optic disc because of raised intracranial tension.
okay. So who said papilledema in the front? So she's saying it is bilateral. Patient has only effective vision in one eye. Okay. So what else? Can papilledema occur unilaterally? Usually papilledema is bilateral passive disc swelling. If it is unilateral, it should be optic neuritis in that way. Okay. So, okay. Carry on.
Okay, sir. So, our patient was a diabetic and hypertensive since 5 years on regular medication. He said his parameters were under control since the past 6 months. There was a history of 3 episodes of loss of consciousness in the past, followed by regaining of consciousness.
Okay, wait. Now, so far we had so many differentials. Does this point towards any one of it? Does this history? What does it point towards? The next person with the mic.
Some kind of embolic phenomenon,
That is embolus
thrombotic, because
okay,
he had
because of history of
past history
CVA.
of CV.
Okay, it could be
TNF.
thromboembolic one. Second, he said vitreous hemorrhage, diabetic retinopathy. It could be there because his patient is a known diabetic for 5 years. But one thing against is he says it was under control. We don't know whether it was actually under control or not, but patient says. Okay, which points that it is against diabetic retinopathy mostly.
One differential is non-atretic ischemic optic neuropathy, common in diabetics, sudden drop in vision by waking up early in the morning.
So, our patient was taking tablet metformin 500 mg HS and tablet telmisartan in the 40 mg in the morning. He denies history of smoking and drinking, and there was no significant family history as well. On general examination, his general condition was fair. His vitals were stable with a blood pressure of 130 by 88 millimeters of mercury and a pulse rate of 76 beats per minute. His cardiovascular, respiratory, and CNS examination findings were within normal limits. His refraction in the right eye was counting fingers at 1 meter with a plano distance correction and less than N36 with a plus 2.50 near correction, not improving any further. His best corrected visual acuity in the left eye was 6.6 with a plano correction for distance and N6 for near with a plus 2.50 spherical power. On external ocular examination, his face examination was normal and symmetrical with no abnormal head posture. On Hirschberg's, he was orthophoric. His eyebrows, eyelashes were normal in the right eye, and the extraocular movements were full, free, and painless. Similar findings were also found in the left eye. On slit lamp examination of the right eye, his lids, conjunctiva, and cornea were normal. His anterior chamber had a von Herrich's grading of 4 and was quiet. His iris was normal in color and pattern with no neovascularization. His pupils were 3 millimeter in size, reacting normally to light. His lens had early cataractous changes, and his intraocular pressure, as measured with Goldman applanation tonometer at 11 a.m., was 10 millimeters of mercury. In the left eye, his lids and conjunctiva were normal as well, with a clear cornea, with a von Herrich's grading of 4 and a quiet anterior chamber, with a normal color and pattern of the iris with no neovascularization, with 3 millimeter size of the pupil, reacting normally to light, with early cataractus changes, and 14 millimeter mercury of intraocular pressure.
Wait. There is one more thing as torchlight examination. That should also be done, and findings confirmed with slit lamp examination. That's how you're supposed to say it in the exam. You should not directly jump to slit lamp examination. And what is more important in torchlight examination in this case? RAPD. Okay. What is RAPD?
Relative afferent pupillary defect.
How do you check for RAPD?
Swinging flashlight test will flash the light on one eye, and within 2 seconds will flash it to the other eye, and we'll check for the.
Does any book give the 2 seconds criteria? It's swinging. You have to move from one eye to other eye. Don't mention 2 seconds, 3 seconds, 10 seconds and all. Okay, then what happens?
So basically, pupil should constrict, but when we swing the light from one eye to other, on the affected eye, there will be dilatation of the pupil. There will be no consensual light reflex.
Pass the mic to the next person. Is there any grade for RAPD? How many grades are there?
4.
4 or 5?
5.
Okay. Anyone knows the 5 grades of RAPD? Okay, read up on that. Okay, so one person says there is RAPD, the next person says no, there is no RAPD. How do you confirm? What is an objective method of confirming the presence of RAPD and saying the grade of RAPD?
Neutral filters will.
Neutral density filters. Has anyone seen neutral density filters? So how do you check RAPD with neutral density filters? There will be excellent videos on YouTube. Okay, it is, you put the filter in front of the eye. The filter is going to block the amount of light that passes to the eye. Okay, so depending on the depending on the grading of the filter at which the RAPD appears and disappears, you put the grade as RAPD present, RAPD not present. If present, what grade it is. There is a table for that. It will be available in most textbooks. Check it up. And how a neutral density filter will be? It will be like a dark gray. The microscope slide you would have seen. No, it will be like that. So check up on that. Okay, carry on.
On gonioscopy of the right eye in dim illumination, we saw 3 quadrants of posterior trabecular meshwork and 1 quadrant of anterior trabecular meshwork, which opened to scleral spur on compression. There was no neovascularization in the angles, and the trabecular meshwork pigmentation was +1. The left eye gonioscopy on dim illumination showed PTM in all quadrants, which opened to scleral spur on compression with no neovascularization in the angles, with a TM pigmentation of +1 as well.
Sir, this is a fundus photo of the right eye.
How do you know it is right eye?
Sir, the disc is on the right side.
The image can be inverted.
Yes, sir.
You can flip the image. It can be inverted. It can be any way around. No.
Sir,
You should ask the presenter who has put it up there. There should be some marking that it is right eye or left eye. There will be annotations usually. This image does not have any annotations.
This is taken on the Zeiss camera. If you see infronasally, there's a marking that always comes on the right. So if it flips, it goes to the left. So you know it's a flip picture. Okay. Even if you take the left eye picture, this will come on the right side bottom. This small marking there.
And this marking can vary in size and shape. The Zeiss model has this marking like a triangle. If you take it with the Topcon model, it will be like a square. It will vary with model to model. The manufacturer sets that. Okay, so this is the right eye. Carry on.
Sir, the media is clear, and the disc margins are blurred. Uh,
Okay,
so the vessels,
that's all in the disc. Disc has around 6 to 7 points, no?
yes, sir. Sir, the cup disc ratio,
Sub-disc
sir,
ratio.
the point 0.6 to 0.7, I think, sir.
Around 0.4 to 0.5. Okay, then
So the neuroretinal rim appears healthy, and
how do you say neuroretinal rim is healthy?
So the color is no pallor.
Said neuroretinal rim is healthy. Okay, you mean to say color. With the color, you will say, okay,
Yeah.
color. What is the color of this disc?
Orangish pink.
What is the normal color of a disc? Is this normal?
It looks slightly hyperemic.
Disc is hyperemic. Okay, normal color of the disc? Pink.
Pink.
Okay, so this is little hyperemic. Then he said neuroretinal rim is healthy. On what basis do you say healthy? One, color should be pink. Second,
The thickness of the rim based on the ISNT rule.
ISNT rule. Inferior, superior, nasal, temporal. Then, okay, what else? Carry on. Pass the mic to the next person. So disc is hyperemic, blood disc margins, cup disc ratio 0.4 to 0.5.
Vessels are
Hmm.
touches vessels are seen. No.
Artery, vein, superior, inferior, all over. Are you actually seeing the vessels there?
No.
Vessels are not clearly visible. Media is also hazy only.
Yeah, it's clear. It's not that hazy. And vessels are minimally tortuous. Though everything is red, 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 if you keenly look, you can see the vessels, the inferior arcade vessels and the superior arcade vessels. The one on the inferior arcade do look minimally tortuous and dilated. How do you say it is dilated? How do you say that the vessels are dilated? What is normal? Before jumping on to conclusions of this case, what is the normal vessel caliber? How do you identify or say that yes, this vessel caliber is normal?
AV ratio has to be 1:2.
Huh? Who agrees? Who doesn't agree? What is normal AV ratio? She says 1:2. What is normal AV ratio?
3.
2:3 is normal. Okay, carry on. What else do you see here?
Which is the artery, which is the vein? You can go and point it out. No? Point it out on the screen, yeah.
Okay, what else do you see? Disc
Tomatoes
done,
flush.
vessels done. Then
There is intraretinal hemorrhage.
there is.
Intraretinal hemorrhage.
How do you say the hemorrhages are intraretinal?
Vessels are above the hemorrhage.
Vessels are above the hemorrhage. You can still see vessels. That means it should be either intraretinal or subretinal. Subretinal can have vessel passing on top of the lesion. So this is intraretinal hemorrhage. So while presenting, you're not supposed to say it as directly intraretinal hemorrhage. You're supposed to explain what you see, then say suggestive of intraretinal hemorrhage. You have to say multiple red lesions noted at the level of retina, suggestive of intraretinal hemorrhages. You can say flame shape, you can say dot and blot, whatever you see, you have to say that, then say suggestive of. Same way, whenever you mention some cottonal spot or something, you should not directly say cottonal spots. You should say fluffy yellowish white lesions seen in the superficial area, superficial retinal layer, suggestive of cottonal spots. That's how you're supposed to say. Okay, that's how you present it in the exams.
So I'll move ahead. So should I describe this image?
No, they all described.
Yes.
So what is this? Other eye. Anything significant here? Fast. Who has the mic? The person left of you. Who has the mic? Pass it front. Is there anything significant that you want to say here? Anything significant? Yes? No?
No, sir.
No. Rutuja, you feel anything is significant here?
No, sir.
See the vessel on top, artery vein crossing above the disc.
Yeah, this one AV crossing change there.
Patient is a known hypertensive.
Known hypertensive, yeah.
There are AV crossing changes. Right?
Yeah.
So just because the right patient came with right eye problem, you should not ignore the left eye. This will also give you clue to what you are dealing with. Does the disc appear pink? Yes, no?
More pale.
Huh?
Pale.
It is because of the light from the fundus camera. Disc was actually pink, but this image is appearing as though the disc is pale, but actually the disc was not pale for this patient. Okay, so always clinical examination is a must, and you can't diagnose patients with images. This is very important when later on when you do teleconsultations. Patient will send you only images. We don't know how the image was taken. We don't know if it's a pale disc or a pink disc, whether the image was taken properly or not. Okay, carry on. This is again a montage image of the right eye.
Should
Anything you want to add?
So in CRVO, we normally describe it as a classic blood and thunder appearance is what we
No
see.
one said this is CRVO. We are just
Whatever we see on this fundus montage image, it looks like a classical blood and thunder appearance with extensive flame shape and dot and blot hemorrhages with macular edema. So I'll summarize my case by saying a 62-year-old diabetic and hypertensive male presented with sudden painless diminution of vision in the right eye since 2 months. He also had a past history of CVA and his fundus in the right eye showed a hyperemic disc with extensive flame-shaped and dot and blot hemorrhages with macular edema. So the differential diagnosis for this case would be a central retinal vein occlusion, diabetic retinopathy, ocular ischemic syndrome, papilledema, and radiation retinopathy. So this is in brief differentiation between ocular ischemic syndrome, CRVO, and diabetic retinopathy. And like Sir said, in case of ocular ischemic syndrome, we would see dilated veins but not tortuous veins. In CRVO, we would classically see tortuous and dilated veins. The hemorrhages in the case of ocular ischemic syndrome would be till the mid periphery, while in CRVO they would be widespread. And even in diabetic retinopathy, we would mainly see it at the posterior pole and at the mid periphery. The optic disc would most likely be normal in the case of an ocular ischemic syndrome. And in CRVO, it would actually be edematous. And rarely in diabetic retinopathy, we can have a diabetic papillopathy. On FFA, the AV transit time is prolonged in the case of ocular ischemic syndrome and CRVO and is usually normal in the case of diabetic retinopathy. So on clinical examination, this case is most likely a case of central retinal vein occlusion in the right eye, probably ischemic in etiology. And I would like to investigate further to confirm my clinical diagnosis.
Why do you tell ischemic first?
So the gross vision loss that we're saying in this case, there are both points for and against for ischemic in this case, because ischemic we would more likely see neovascularization in that case, that we can't see. The RAPD is not documented for this case. Ischemic
When
would
does neovascularization happen in CRVO?
so when there's mainly ischemia, that is when the VEGF gets secreted and then there's neovascularization.
Time point of appearance of neovascularization.
So within 100 days from onset.
Yeah. So this is how many days?
This is just 2 months now. It can happen. We'll have to follow up the patient to see.
Yeah. So
Yeah.
yeah, it can happen, but yeah. Okay.
So FFA, OCT, anything else you people want to do? What blood investigations? Coagulation profile. Then for what do we want homocysteine in this patient? Patient is a 62-year-old, right?
Yeah.
Cardiac
Usually-
imaging.
Usually homocysteine is done for patients with
Young patients.
young vein occlusions. Okay, young patients with vein occlusions or young patients with stroke. Okay, cardiac imaging. What do you mean by the broad term cardiac imaging? Carotid Doppler comes under cardiac imaging.
ECG, echocardiogram.
ECG, echo. Then what are we aiming to find out with ECG, echo and all? Look at some
Source of embolus.
source of embolus. Yes, thrombus or embolus, which is coming from the heart. It could be anything. It could be a aortic regurgitation also, which is throwing up thrombus. Okay, so what else? Blood sugar. Then what else?
There are basic CBC exam.
What do
PT.
we identify by CBC?
Sir, anemia profile will want to see for the patient.
So one more differential for this patient, anemic retinopathy. Okay. So when you order an investigation, you should know what you're expecting. You should not order a panel of investigations and everything comes back normal. Okay, you know why you're advising. Okay, very good. Anemia. Then
A plate, prothrombin time, APTT, and coagulation profile. Yeah.
that and all they said. What else?
Lipid profile.
Lipid profile. Very good. So patient can have dyslipidemia also. What else?
Acute reactant CRP. CRP ESR.
CRP ESR. Very good. Then
Thyroid function test.
Hmm?
Thyroid function test.
Thyroid function test. Okay. 2022, 2020, 2021, we had a major outbreak. COVID can cause vein occlusions, right? So COVID antibody titers are also one of the investigations that you need to do at this point of time. History of COVID vaccination should also be included. What sort of a vaccine, whether immediately after vaccine this occurred or whether little late after the vaccine, whether vaccine is related to this or not, that history is also important. Then, okay, carry on.
So this is an
CBC, somebody told, you'd want to look at the smear also. Okay. Because rarely CML can also present as CRVO. Okay.
I'll go ahead. So this is a spectral domain OCT image of most likely the right eye, which is going from the temporal to the nasal side, from left to right of the scan, showing a clear vitreoretinal interface and intraretinal cystic spaces suggestive of gross macular edema. Intraretinal distorted.
They are little hyperreflective.
Hyper.
Hyperreflective inner retinal layers suggest there is retinal ischemia. Goes more in favor of ischemic CRVO.
This is an OCT, SD-OCT image of the left eye of the same person with the nasal to temporal orientation, as we can see from the RNFL. And this is the normal OCT scan with a normal foveal contour.
Today she's presenting a case, so she's moving on. But when you're presenting an OCT, you should explain it layer by layer. Even though it is normal, you should say this layer normal, this layer normal, that layer normal. Everything you should go layer by layer. Okay.
The nasal part of the outer plexiform. Do you think it is normal?
Nasal part of the outer plexiform.
Just nasal to the fovea.
There's one hyperreflective foci that we can see.
Okay, it's not fully normal. Yeah. Okay, go ahead.
So the systemic investigations done in our case were serum homocysteine, which was normal. We also did a 2D echo, which showed a left ventricular hypertrophy with an ejection fraction of 50%, a trivial atrial regurgitation, a mild mitral regurgitation, and no obvious clot was seen. On carotid Doppler, there were atherosclerotic plaques causing 20 to 25% stenosis of the left ICA. The treadmill stress test was strongly positive for myocardial ischemia. The plasma high sensitive troponin 1 was elevated, and an MRI showed old infarct in the left cerebellum, small vessel ischemic changes, pontine ischemic changes as well. So, according to our cardiology evaluation, this patient was declared unfit for an anti-VEGF injection at present, and an option of intravitreal injection of dexamethasone implant, that is Ozurdex, was given to the patient after explaining the risks and benefits of the same and after stabilization of the systemic disorders. And for the time being, we prescribed the patient topical Nepafenac eye drops 0.01%. So here we'll be discussing about the differences between non-ischemic and ischemic CRVO. So the best corrected visual acuity in the case of a non-ischemic CRVO would be better than 6 by 60, while in ischemic it would be worse than 6 by 60. RAPD, as we would check it with a swinging flashlight test or a neutral density filter, would most likely be absent in a non-ischemic CRVO and present in the case of ischemic CRVO. And objectively, it would be more than 0.9 log units. On iris examination and gonioscopy, we would not see any neovascularization in the case of non-ischemic, whereas in the case of ischemic, we would see neovascularization. So basically, 35% of these non-ischemic is present in 80% of the patients, and ischemic is present in 20% of the patients. So 35% of these 20% eventually end up developing neovascular glaucoma. Optic disc in the case of non-ischemic CRVO may be hyperemic, and ischemic would have marked optic disc edema. The retinal veins in the case of non-ischemic would be mildly dilated, whereas in the case of ischemic would be markedly dilated with tortuosity. The hemorrhages would be mild to moderate, more in the periphery in the case of non-ischemic, whereas in ischemic there would be extensive hemorrhages involving the periphery and the posterior pole, as seen in our case. The cotton wool spots would be rare in the case of non-ischemic, whereas they would be present in the case of ischemic CRVO. The macula may be normal or may show edema in non-ischemic, whereas there will be gross hemorrhages and edema in the case of ischemic. The prognosis in general for a non-ischemic CRVO would be good, whereas it would be poor in the case of ischemic CRVO. And on doing an ERG, in the case of ischemic CRVO, we would see a decreased B wave amplitude less than 60% basically, which would suggest that it's an ischemic CRVO, and this test is 80% sensitive and specific.
Okay. So as she said, the differences between ischemic and non-ischemic CRVO, not all will be present in a single patient. Okay. It may be 2-3 points towards ischemic, 2-3 points towards non-ischemic. It will be like that only. If a patient of ischemic CRVO comes, everything there won't be positive for the same patient. So you should not expect everything in a single place. Okay. So anyone wants to say what our case is right now, ischemic, non-ischemic?
So I would keep ischemic as the probable etiology right now. I'll follow up the patient. I'll see, since it's only been 2 months, I'll follow up the patient and see if that patient eventually does develop any neovascularization. I'll do an undilated pupil examination again to see if there is any RAPD. And I'll do an ERG as well to see if there is any decreased P wave amplitude in this case.
FFA.
And an FFA after systemic stabilization.
Yes.
So this is a left eye pseudo color image of the pseudo color wide field image of the left eye, which shows a clear vitreous cavity. The disc looks hyperemic in appearance and with blurred disc margins. The cup disc ratio cannot clearly be made out in this picture. We can see dilatation of the retinal veins along with tortuosity, and the retina shows extensive flame-shaped hemorrhages, which are mainly in the mid-periphery, along with dot and blot hemorrhages.
Slide.
So the vessels are more tortuous.
Vessels are more tortuous compared to the case we presented. Then, how are the hemorrhages?
Dot and
less?
blot seem to be more.
It is more,
than
less, more or less?
less.
Less, comparatively less hemorrhages, more tortuosity, more dilatation. Then, okay, carry on. What do you say this is?
So I'd like to compare the vision for this patient But depending on this, the hemorrhages seem to be lesser, so most likely non-ischemic, though the tortuosity does look more in this case.
So as we said in the table, not everything will be present in the same case. Tortuosity more points towards ischemia, hemorrhages less points towards non-ischemia. So it will always be a mix and match. Okay, carry on.
So this is
This, what is this? What image is this? Previous one was a ultraviolet field pseudo color image. What is this? Why is this specifically put up here?
Is it autofluorescence? Fundus of autofluorescence.
The red free image.
Free.
Why do we want a red free image here? What advantage does it give?
Hemorrhages are seen clearly.
Yes, we'll be able to appreciate the hemorrhages or microaneurysms or whatever it is more better, because with a normal color fundus photo, everything is red on red, orange on orange. This will be black on gray. So the contrast sensitivity of the examiner for us is better this way. So we'll be able to appreciate things better.
Yeah. So this is an ultra-wide field fluorescein angiography image of the right eye of a patient. The first image showing a choroidal flush. The second image is showing the arterial filling in this case. The third image is showing us the artery and venous filling along with the gross tortuosity of the vessels that we can see in this case. There are some areas of blocked fluorescence as well.
Normal
Depending on-
fundus photo should be present initially, so they should take one without the fluorescent dye.
Okay.
Time.
FFA is always time based, so there should always be a timer somewhere on the image. At what time was this image taken should be put up. Okay. Okay, carry on.
The fourth image is showing us some peripheral areas of non-perfusion. There is no macular ischemia per se.
And again, you're not supposed to present it as non-perfusion. How do you present it?
Hyperfluorescent areas, hypofluorescent areas without.
Yes, that's how we are supposed to present.
So we'll just discuss in brief about the studies for CRVO. So the central CVOS trial, they basically had two arms, the CVOS M and the CVOS N trial. So the M spoke about the grid argon laser photocoagulation, and the conclusion was that there is no benefit from doing a grid argon laser photocoagulation for eyes with macular edema due to CRVO. The CVOS N trial basically spoke about doing an early PRP. So they came to a conclusion that prophylactic PRP did not actually prevent neovascularization in the angles or the iris, and prompt PRP was recommended in eyes which had neovascularization later. The SCORE treatment trial was for IVTA. So they had three groups, one in which they gave 1 mg preservative-free IVTA, the other one 4 mg preservative-free IVTA, and the third one was an observation group. And they concluded saying that IVTA was superior to observation for treating vision loss associated with macular edema secondary to CRVO. And the safety profile for the 1 milligram dose was superior to that of the 4 milligram dose. The Geneva trial was about dexamethasone. So one arm got a 0.7 mg of dexamethasone, the other one was 0.35 mg, and then there was a sham arm. And the dexamethasone implant group compared with the sham group had better improvement in BCVA. They had no significant difference in the effect on IOP and no significant difference in the effect on the occurrence of cataract. The cruise trial spoke about the injection of razumab. So intravitreal injection, the first arm had a 0.3 mg intravitreal injection of razumab, the other one was 0.5, and the third was sham injections. So injection of intravitreal razumab provided rapid improvement in 6-month visual acuity and macular edema following CRVO with low rates of ocular and non-ocular safety events. The Copernicus and Galileo trials spoke about injection of aflibercept and sham injections. At 24 weeks, the monthly intravitreal aflibercept 2 mg in eyes with macular edema resulting from CRVO, they showed improvement in visual acuity and the central retinal thickness and eliminated progression resulting from neovascularization. It was associated with low rates of ocular adverse events related to treatment. Then the bevacizumab trial for RVO. So, 3 initial injections of bevacizumab, that is 1 milligram at monthly interval, and retreatment based on the central retinal thickness, which was measured on OCT. So they said that intravitreal bevacizumab was safe and effective in patients with macular edema secondary to retinal vein occlusions. The SCORE 2 study spoke about the injection of intravitreal bevacizumab and intravitreal aflibercept, and it showed that injection of intravitreal bevacizumab was non-inferior to that of intravitreal aflibercept with respect to visual acuity after 6 months of treatment among patients with CRV or hemiretinal vein occlusions.
Okay. She continuously spoke for 5 minutes. How many of you understood what she spoke? Someone summarize the entire slide in 2 to 3 lines or 3 to 4 lines. What is the inference that we gain from this slide? What to do, what not to do? Just 3 to 4 lines. Summary, that's all.
Sir, grid laser photocoagulation for macular edema secondary to CRVO is not advisable.
Yes, agreed.
Prophylactic PRP has no role for CRVO.
Agreed.
And sir, then intravitreal triamcinolone 1 milligram has better safety profile than 4 milligram. And intravitreal dexamethasone shows better results than bevacizumab. And
yes, so we have 2 treatment options: intravitreal steroids or intravitreal anti-VEGFs. Each anti-VEGF compared to each other, nothing is superior or inferior to each other. Everything is almost going to act the same. Steroids have a marginal better role, better efficacy, and no role of prophylactic laser for CRVOs. Only when the patient develops neovascularization, you are supposed to do a PRP. No role of grid laser at all. Okay, this is the conclusion of this slide. Move on.
So we'll talk in brief about the recent advances. So chorioretinal venous anastomosis. So by bypassing the occluded central retinal vein by creating a chorioretinal anastomosis between a nasal branch retinal vein and a choroidal circulation. So this anastomosis would actually allow transretinal retrograde flow of the venous blood from the eye and prevent development of retinal ischemia or allow reduction of CMA. So the technique is by transretinal venipuncture technique or by argon or neodymium YAG laser delivery at the branch retinal vein to rupture the posterior vein wall and the Brooks membrane. The complications with this procedure are intraretinal, subretinal or vitreous hemorrhage, epiretinal membrane, fibrovascular proliferations, and secondary neovascularization. The other one is usage of tissue plasminogen activator. So, recombinant tissue plasminogen activator is a synthetic fibrinolytic agent that converts plasminogen to plasmin, which eventually destabilizes the clot, causes dislodgement of the thrombus, and recanalization of the vein. Routes of administration are systemic, intravitreal, endovascular cannulation of retinal veins. The other one is radial optic neurotomy. So basically transvitreal incision of the nasal scleral ring to release pressure on the central retinal vein at the level of the scleral outlet. So the risks associated with this procedure are laceration of the central retinal vessels, globe perforation, choroidal neovascularization, subretinal hemorrhage, and retinal detachment. These are my references.
So everyone can go and read up about the recent advances. Many people are trying a lot of things. And regarding case presentations, even though you know the diagnosis in the beginning, don't utter words only towards the diagnosis. You should always have differentials. You should think in a broad manner and then come and conclude to a diagnosis. And always have treatment options available. Don't have only one option with you, and if that is not possible, you'll be stuck in the middle of a forest. So have multiple treatment options available. Choose what is best for the patient. Explain each treatment option available to the patient. For example, this patient was if at all he was fit for anti-VEGF, he had two options. He had steroids also, intravitreal steroids also. He had anti-VEGF also. So give the option to the patient. Explain the risk and benefits of both. Let the patient decide. Okay. So that way. Otherwise, you presented well. Very good.
Yes, sir. Thank you for the guidance, sir.